pregnancy that can either be dizygotic twins, 2 sperms, 2 eggs producing 2 babies, or monozygotic twins, 1 sperm, 1 egg that produce a single mass of tissue that at some point from day 1 to day 12 and beyond splits into producing 2 babies. The stage of cleavage also defines the type of monochorionic twins. In 1/3, and this is something to remember, number 3 as far as monochorionic twins go, 1/3 of monochorionic twins will occur where there is cleavage within the first 3 days of fertilization. And at this stage, have 2 babies, 2 placentas, 2 amniotic sacs, dichorionic monozygotic twins. Then until day 9, at the blastocyst stage, splitting produces now 2 babies, 2 amniotic sacs, but sharing of the same placenta. Splitting beyond day 9, we end up with a single amniotic cavity and a single placenta. And if Leona, is there a problem?
We can't see your slides.
Really?
Yes.
This is a disaster. Why is that?
And we can only see your desktop. We can see that you were clicking the PowerPoint, and would you be able to...
Let me stop sharing and start again. So, this is twins. What about now, Leon?
Yes, now you can, yes, perfect.
Yeah, okay, I said topics in twins. Topic 1, zygosity chronicity. You have 2 types of twins, dizygotic, 2 sperms, 2 eggs, monozygotic, 1 sperm, 1 egg, with subsequent splitting at different stages of development. Splitting within 3 days of fertilization, 2 babies, 2 placentas, 2 amniotic sacs. 9 days, we have 2 babies, 2 amniotic sacs, but sharing of the placenta. At the implanted blastocyst stage, 9 to 12, 1 amniotic sac, 1 placenta, 2 babies, and then splitting beyond day 12, we just have conjoined twins. Okay. Now, how can we determine zygosity and chronicity? This guy, Walter Sepulveda, from Chile, when he was a fellow at King's a few decades ago, described at the time of the 11 to 13 week scan. In the early 1990s, with nuchal translucency, we moved to the first trimester, and at that time, we defined the criteria. And basically, you look at the junction between the intertwin membrane and the placenta, and if there's a bit of placenta extending into the base of the intertwin membrane, that is dichorionic. And if and this we call the lambda sign, is a Greek capital inverted lambda, or the white lambda, or what I now call the black lambda, which is exactly the same. Just see one membrane that splits at the base, but now instead of this being white, it's black. Or alternatively, we call it the T side. This is monochorionic, this is dichorionic, and it's pretty accurate, really. After 16 weeks, quite often, this white tissue becomes thinner and thinner and becomes increasingly more difficult to distinguish between monochorionic and dichorionic. That's all, really. Now, let us start with, again, back to the principle of 3. We start off with 9 twins. Again, the number of threes, 2/3 are dizygotic, of the 9, therefore 6. 1/3 are monozygotic, of the 9, therefore 3. All dizygotic are dichorionic, but 1/3 of monozygotic, those that split within 3 days of fertilization, will also be dichorionic. So we have now 9 pregnancies, 2 monochorionic, always monozygotic, 7 dichorionic, but of the 7 dichorionic, 1 is monozygotic and 6 are dizygotic. So if you see a monochorionic twin pregnancy, they are identical. And if you see a dichorionic twin pregnancy, they are mostly non-identical, but there are some that are still identical. Dating of the pregnancy. Okay. In the 1990s again, when we could see two babies in a twin pregnancy, I said, it may be that the small baby has an abnormality, and therefore we should date the pregnancy based on the size of the big baby. I just one morning woke up and I said, that sounds logical, and that is what we should do. And this is what subsequently, over the decades, the various professional bodies said. The American College of Obs and Gynae are still thinking about it. The Society of Obstetricians and Gynecologists in Canada, they said we must use in the case of the spontaneous, the fetus with the highest CRL, like I said that morning in 1992. And the Royal College of Obstetricians and NICE guidelines say that irrespective of whether you have spontaneous or assisted reproductive techniques, we should just ignore what the women are saying, even if they have IVF, and use the fetus with the highest CRL. Why? Well, it's tradition. Is this true? Recently, with Pediatra Viva from Bulgaria, where they have a very big IVF center, we looked at 539 IVF pregnancies, and this is the result. The blue diagonal lines is the perfect agreement between gestational age from IVF, when we know when they got pregnant, and the gestational age from the CRL. And when we look at the largest twin, the red one here, you can see that the baby is larger than what it should be. And therefore, it is wrong now to rely on the largest twin for defining gestational age. The smallest, actually, CRL is more logical, but because a few of the small babies may be small because they're abnormal, it may be silly to rely on that baby for the calculation of gestational age. And the good compromise is to use the average CRL for the calculation of gestation. So 1992, the biggest, 2023, definitely the average. What about the labeling of twin? Is it important to know which is twin 1 and twin 2, and how do we go about it? Well, we divide the uterus according to where the intertwin membrane is. We try to define the position of the cervix and where the membrane is. And by definition, if you're going to have vaginal delivery, this baby will drop out first. So this is twin 1, and this is twin 2. It may become difficult later on as the pregnancy advances to find exactly, transabdominally at least, the junction between the uterine wall and the lower end of the intertwin membrane. But this is how we we define the position of the babies, 1 and 2. Is it important? Well, it is important because if we go into the first trimester, for example, and we calculate the pregnancy is dichorionic, and we're calculating the risk for aneuploidy, it's important to know which baby is which, or a fetal abnormality, or we are going to need to do either an invasive test or a selective termination, not to do a major mistake. And therefore, it is important to define as accurately as possible the position of the babies and decide which baby is number 1 and which baby is number 2. And of course, when you subsequently do serial scans, because all of twin pregnancies will need many, many scans during the course of the pregnancy, not to be interchanging the measurements. Sometimes you plot the graph of the various measurements for the various visits, and see that one baby becomes bigger in visit 1, and then smaller in visit 2, and so on. So it is important in terms of early diagnosis, invasive testing, selective termination, and monitoring of growth for later on. And of course, when the babies are born, it's good to know and let the pediatricians know which baby we are expecting with a problem versus a no problem baby. So that is that. Let us now go to another topic, screening for chromosomal abnormalities in twin pregnancies. And here it's important to always step back and say, what are we trying to do? We have to define chorionicity. We need to determine whether the pregnancy is dichorionic or monochorionic by definition. If the pregnancy is monochorionic, almost invariably, if one baby has a chromosomal abnormality, the other baby also has the same. But the opposite is true. in the case of dichorionic twins. If one baby has a chromosomal abnormality, unless is that 1 in 7 that is also monozygotic amongst the dichorionic, the rest is extremely unlikely that the other baby will also be affected. So step 1, determine chorionicity, and then start thinking of how do we go about defining risk for chromosomal abnormalities. And then we have the problem, which at the 11 to 13 week scan, in about 1 to 3% of cases, you will find one alive baby and an empty sac or another sac with elements of, or fragments sometimes, of a dead other fetus, vanishing twin. Okay, let us go to the traditional method of screening from a few decades ago, but still common in many countries. And this is second trimester serum biochemistry, low AFP, high HCG, low estrogen, high inhibin A, puts you at a high risk of a chromosomal abnormality. In singleton pregnancies and in monochorionic twins, we must always think in terms of screening for chromosomal abnormalities that singletons and monochorionic twins come as a package. They're similar. The performance of screening is about 70% for the detection of Down syndrome at a screen positive rate of about 5%. In dichorionic twins, it's a disaster. This falls down to 40%. Why? We are looking at placental products. And if one baby has a chromosomal abnormality and the other baby is normal, the products from the normal placenta are shadowing the abnormality from the abnormal placenta. And therefore, the performance of screening is much poorer. So no good, really, doing second trimester serum biochemistry in screening for aneuploidies in dichorionic twins. What about the first trimester screening? Well, much better, but there is a small problem, and the small problem relates basically to nuchal translucency in monochorionic twins. A high nuchal may be a marker of Downs, for example, but it can also be a marker of early twin-to-twin transfusion syndrome in the recipient twin. Because of that, the screen positive or false positive rate of the first trimester combined test in screening in monochorionic twins is not 5% as it is in a singleton pregnancy, or 6% as it is in a dichorionic twin pregnancy, but it's double that, it's nearly 9%. So beware. We determine chorionicity, we look in dichorionic twins at each baby separately, and we calculate the risk for each baby separately. In dichorionic twins, one baby may have a risk of 1 in 10 because it has a very high nuchal translucency, and the other baby may have a risk of 1 in 10,000 because the nuchal translucency is very, very low. In monochorionic twins, we pay attention to discordance in size between the two babies and discordance in nuchal translucency. On the left bottom here, you can see pairs of monochorionic twins where both babies have Down syndrome. And you can see that this pair shows that both babies have a very high nuchal translucency, but this pair shows that one has a very, very high nuchal translucency and also has an element of being a recipient. And this baby has a very low nuchal translucency, equally Downs, but in this case, this baby is like a donor. So be careful. In monochorionic twins, you may have similarly high or similarly low nuchal, or you may have a widely separate nuchal translucency measurements. So how do we go about screening? On what do we rely? Well, you rely on the average measurement of the two. And the era of self-DNA testing. On the left, the results from a large series from our group, plus a meta-analysis, massive numbers, nearly 2,000 cases of trisomy 21, more than 500 of trisomy 18, and more than 100 of trisomy 15, which shows really that self-DNA testing is quite reliable for all 3 trisomies in singleton pregnancies with a low false positive rate. What about twin pregnancies? Disaster. the number of reported cases, not the propaganda leaflets from companies, the number of reported cases is extremely small. Only 137 cases of trisomy 21, which shows a very good result, a detection rate of 99% and a very low false positive rate, but you can't really make any comment whatsoever for the case of trisomy 18 and 13. So what can we say today, 2023? We can say that in twin pregnancies, screening by cell-free DNA testing for downs appears to be reliable. For trisomy 18 and 13, the number of examined reported cases is too small to give an accurate estimate of the performance of screening. What about vanishing twins? Here we have a problem because cell-free DNA testing is looking at DNA that comes from dead placental tissue. So surely the dead fetus, the vanishing twin, has a dead placenta, and therefore the contribution of the dead placenta in the maternal circulation often may be higher than the contribution of the live twin. So if the baby died because it had a chromosomal abnormality and the surviving baby is normal, we are making the wrong diagnosis of a chromosomal abnormality in a normal baby, but in reality, that is reflecting the dead fetus. So you cannot really offer a cell-free DNA test in vanishing twins unless there's a very long interval between the time of death and the time of testing. How long? Well, there are some case reports that say that you can still have discordant results of contamination for as long as 15 weeks after the death of the fetus. What is 15 weeks? It means that even if the death of the one embryo is at 6 weeks, we may be getting unreliable results for as late as 20 weeks. So beware of this problem. What about the combined test, nuchal, HCG, and PABA in vanishing twins? In this graph, in many, many thousands of patients, the blue line is normality, and the rest is in vanishing twins. We looked at HCG. As soon as the baby dies, HCG drops to normal. And therefore, even within a day, the HCG from the dead fetus disappears. So what we are measuring in the amniotic, in the maternal blood is the HCG of the surviving fetus. So we can use HCG in the assessment of risk. What about PABA? You can see here that even if you, at 12 weeks, you have an empty sac, which means that the baby died at 5 or 6 weeks, still, for some weird reason, the PABA remains high. And before, let's say, 5 weeks, the earlier, the shorter the interval between death and testing, the higher the PABA. Conclusion, don't use PABA in the calculation of risk, just rely on the measurement of nuchal translucency, maternal age, and HCG. Is that a big loss? A bit of a loss. By using for a 5% false positive rate, if we just rely on nuchal, you have a detection rate of about 80%. If we rely on HCG plus nuchal, we get up to 86%. If we also have PABA, we get to 91%. So by ignoring the results of PABA, well, not a big deal. We still have a very good detection of 86%, and the loss is only about 5% in detection rate. Let us now go to invasive genetic testing. What do we do? Well, in monochorionic twins, different people do different things. My attitude is to sample one. If one is normal, the other one is abnormal. If you're doing an amnio, you just put a needle into one of the sacs. If you're doing a CBS, you put a needle into the placenta and you try to go up to the edge so that in one needle, you are aspirating placental fragments from across both elements of the placenta. In the unlikely event that you will get a mosaic result, then you investigate further. That may be reflecting that the one placenta is chromosomally abnormal, the other is not, and that's why you're getting this mixture of a mosaic result. But in general, I sample only one of the babies. There are very rare occasions where in monochorionic twins, one baby has a chromosomal or a genetic condition and the other does not. What about dichorionic twins? Well, there we do have a problem. If you do an amniocentesis at 16 weeks, then you have to be absolutely certain that you have sampled the two sacs. There are two techniques of doing that. The technique which most people use, you go to one edge of the placenta of the uterus and you sample one baby with one needle, and then you go to the other end and you sample the other baby. What I usually like to do is I enter the sac of one baby, I aspirate amniotic fluid, and then I image very carefully the intertwin membrane, and then I go across the intertwin membrane into the other sac, and then I aspirate fluid from the other sac. So in one go, I get both sacs. Is that the best thing to do? I think not. The best thing to do is to do a CVS. Why so? And what is the problem with doing that? The intertwin membrane is not always at the junction from the two placentas. So a mistake that you may make by looking at the intertwin membrane as the junction for separating the two placentas is that the one placenta may be extending beyond the intertwin membrane. And if you're not careful, you're sampling the same baby twice. So what I would do is I would go to the one extreme end of the placenta and take a sample from one baby, and the other extreme end of the placenta and take a sample from the other. I prefer CVS because of what do you do next. And what do you do next is consider the option of an embryo reduction. And embryo reduction at 12 weeks is a hell of a lot safer than embryo reduction at 16 and 18 weeks, both in terms of subsequent miscarriage and subsequent preterm birth. So if I had a choice, I would go for a CVS each time. Now, what is the risk of these invasive tests? In the case of amniocentesis, a few decades ago, a great woman and a good friend of mine, Antenatal, in Denmark, did a randomized trial of comparing doing nothing versus doing an amniocentesis. And she found that the risk of miscarriage in the amniocentesis group was about 1% higher than in the control group. And that established for us in fetal medicine for the last 40 years that the risk of invasive testing is 1% higher than if you do nothing. There has never been, and there will never be, a trial of comparing CVS versus, I mean, this would be completely unacceptable. So people are doing all sorts of different things. They are selecting groups of women that had a CVS versus groups of women that did not have a CVS, and they're trying to compare them. And this is what we did in this study. We took 8,500 twin pregnancies at 11 to 13 weeks. And in this group, there were 316 dichorionic twins and 129 monochorionic twins that had an invasive test. And what was the result? In the group that had the invasive test, the red histograms, there was quite a bit more of a miscarriage or overall fetal loss than in the group that did not have an invasive test. But that's a bit of cheating, really. Why? Because the reason why somebody has an invasive test, for example, in the context of chromosomal abnormalities, is because the woman is older, the nuchal translucency is increased, or the PABA is reduced. But these very three factors, advanced maternal age, high nuchal, low PABA, are the very same factors that if you just say hello to the woman, carries an increased risk of miscarriage. So within the group that had a CVS, they already had a higher chance of miscarriage even before they had a CVS. When we correct for that, then we arrive at the conclusion that most of the excess risk of miscarriage from invasive testing like CVS in twins is derived from the reason why you do the invasive test, and maybe the risk of miscarriage is no more than the additional risk of miscarriage than about 1%. Let us now look at the outcome of twins, and that depends on when we start looking at them. In this study of more than 6,000 women, we looked at them with 2 alive babies with normal-looking babies at 11 to 15 weeks. And we divided them into dichorionic, monochorionic, and monoamniotic. And for the sake of comparison, I also put data from more than 150,000 singleton pregnancies that we examined at the same time. What is the risk of miscarriage before 24 weeks? In a singleton pregnancy, the numbers are very simple. Between 12 and 24 weeks, 1%. Dichorionic, 2%. Monochorionic, 8%. Monoamniotic, 22%. And then we go to late death beyond 24 weeks, 0.4, 1, 2.5, 9. And then we go to preterm birth, 2, 7, 14, 27. And then we go discordance in size, with one baby being at least quite small, 5% below the 50th centile, 30% in dichorionic, 38 in monochorionic, 33. So about 30% versus 5%. And you can see the survival curves on the right. Dichorionic twins worse than singletons, monochorionic twins a lot worse, and monoamniotic a hell of a lot of higher risk of death at some point. And that establishes the basis of counseling when we see a woman at 12 weeks. You can tell them really that this is what we are expecting, and our objective is to see whether we can avoid some of these deaths, and therefore what measures can we take, what sort of monitoring can we undertake to minimize these risks of death. And that's exactly where we go in terms of antenatal monitoring. Dichorionic twins, you see everybody at 12 weeks, you do a first trimester anomaly scan, like Leona will be telling you later on the guidelines of what do you actually look. And then the next scan is 20 weeks, and then 4 weeks thereafter, and aim for delivery at around 37 weeks. After 37 weeks, you have this increase in the rate of stillbirth. So there's no point in struggling to keep pregnant a twin dichorionic pregnancy beyond 37 weeks. Get them all out. Monochorionic diamniotic, there you have the problem of twin-to-twin transfusion. The first elements of where you could potentially intervene after 12 weeks is about 16 weeks. So as far as I'm concerned, see them at 16 weeks, and every 2 weeks thereafter, right up to delivery at 36 weeks. If you see a discordance in amniotic fluid, in fetal size, in Dopplers, then see them every week. And in monochorionic, you follow the same protocol, because actually there isn't much that you can do in terms of interventions in monochorionic. You cannot hospitalize them, it doesn't really help. You cannot do lasers, you just follow them up for psychological support for yourself and the parents that things are going well or not. And what do? On each occasion, you measure both babies, you assess the amniotic fluid, you do Doppler, and I write anatomy. It's because of my ideology. You never do an ultrasound scan to measure the abdominal circumference and then say bye-bye. We are looking at a very high-risk type of pregnancy where things can go dramatically wrong between visits. You may get a hemodynamic change, you may end up with hydrocephalus, a brain damage, a cardiac evolution of a cardiac dysfunction in one of them. So don't just measure the femur and the head circumference and say, bye-bye, see you in 2 weeks. On each occasion, try to do a mini anomaly scan. Look at the brain, look at the heart, look at the abdomen, see how the baby is growing. At 20 weeks, measure cervical length as a predictor of preterm birth. And then on each occasion, size of both babies, amniotic fluid assessment of both babies, Doppler. What is Doppler? Doppler means umbilical artery, ductus venosus, and middle cerebral artery. That is Doppler, nothing more and nothing less. Let us talk about preeclampsia now in twins. I'm sorry, I'm rushing to cover as many topics in twins as possible. Is it common? Is it rare? Is it the same as in singletons? In general, the rate of preeclampsia in twin pregnancies is 3 times higher than in singleton pregnancies. But that is a bit of a cheat, because the majority of twins deliver prematurely and very few singletons deliver prematurely. So we cannot compare total duration of singletons, total duration of twins, and see what is the incidence of both. In order to have a valid comparison between them, we need to look at preterm preeclampsia. And when you do that, the rate of preterm preeclampsia in twin pregnancies is 9 times higher. So, as I am all twins are at a substantially increased risk of preterm preeclampsia. The very group where we showed with Leona that there's a benefit in singleton pregnancies from aspirin, but you haven't got the faintest idea whether aspirin is actually beneficial in reducing the rate of preterm preeclampsia in twins. And that is why we have undertaken a trial that would hopefully give us results in 2 or 3 years as to whether aspirin, 150 milligrams every day from 12 to 34 weeks in twins is as good as it is in singletons. At the moment, we do not know. Preterm birth, the leading cause of death and handicap, both for singletons and twins. What is happening now in twins? Well, the first thing is in this large series of our group, the risk of delivering before 34 weeks, which is the dangerous period for preterm birth, in a singleton pregnancy is about 1 to 2%. In twins is 10 times higher when they're dichorionic, and when they're monochorionic, they're 15 times higher. Disaster. So the biggest problem in twins is the massively higher rate of early preterm birth, especially when they are monochorionic. In singleton pregnancies, we have found over the decades that if you measure the cervical length at 20 weeks and the cervix is short, you can put in a stitch, you can give in progesterone, and some people think, I don't think, but some people think that putting in a pessary is useful and it can reduce the rate with each one of those interventions of early preterm birth by about 30 to 40%. What about twins? Nothing. Bed rest does not work. Cervical cerclage for a short cervix does not work. If anything, there's a tendency to increase the risk of premature birth. What about cervical pessary? It does not work. In this meta-analysis by the group of Roberto Romero, where they included me, it doesn't help. And what about progesterone? Giving routinely to everybody from mid-gestation, it does not help. So here we have a condition which is a hell of a lot more common in twins than in singletons, and yet we can do nothing about it to prevent premature birth. Is there something we can do? I just did a major study involving many thousands of women where I gave very high doses of progesterone, 600 milligrams of progesterone every day, starting from 12 weeks in twin pregnancies. Was that beneficial? Not at all. If anything, we nearly crossed the line here at the bottom end and showed that perhaps giving progesterone to everybody may be increasing the risk of premature birth. And you can see on the right, the blue placebo, red progesterone, no difference whatsoever. So even very high doses of progesterone starting from 12 weeks doesn't really help. However, in a very small subgroup of patients, we found that if the cervix is short from the first trimester, perhaps in that small subgroup of women, there is a benefit from giving high doses of progesterone starting from 12 weeks. And then structural defects in twin pregnancies. Well, the incidence of a structural abnormality in one of the two babies is higher in monochorionic twins than in dichorionic twins. And the reason for that is very simple. Monochorionic twinning in itself is an abnormality. And during this splitting of a single cell mass to produce two babies, there is an increased risk that some of the cells that are committed from the midline are already only taken by one of the baby, and therefore you have a substantially higher chance that in monochorionic twins, one of the two babies will have a higher incidence of midline abnormalities, from anencephaly to facial cleft to cardiac defects to exomal loss and, for example, spinal bifida. And the detectability of abnormalities in monochorionic twins at the 12-week scan is also better than in twins dichorionic. And the reason for that is that the abnormalities, that the excess abnormalities that you have in monochorionic twins are more devastating. You can have trap sequence, you have major exomal loss, anencephaly, so it's easier. Conjoined twins, it's easier to pick them up at the 12-week scan. And what do? I have already alluded to that. If you are in a country where abortion is legal, the blue histograms show what is the benefit of doing an embryo reduction at 12 weeks, a lower subsequent risk of miscarriage and subsequent risk of premature birth than if you do the embryo reduction after. The later you do the embryo reduction, the more the dead tissue in the uterus at the end, and therefore the higher the risk that you will end up miscarrying as a result of your intervention. And we knew that from my good friend Mark Evans when he approached me many decades ago, 30 years ago, and various other leading centers in the world. We gave our results and he looked at them all together, and this is the conclusion. So if you're going to do an invasive test in twins, do it at 12 weeks, not at 16 weeks. And if you're going to do an embryo reduction, do it at 12 to 13 weeks, not at 18 to 20 weeks. Let me now try and skip some of this because we're running out of time and I want to leave more time for discussion. What are the complications of monochorionic twins? There are 4 basically. Severe TTTS, 1 in 10. Selective growth restriction, where one baby is small and the other is normal, 1 in 10. Trap sequence, 2 in 100. And TAPS, where one baby becomes progressively anemic and the other polycythemic, about 5 in 100. And each one of these 4 complications looks different, and each one has a different type of management. Twin-to-twin transfusion syndrome essentially staged by looking at these polyhydramnios, oligohydramnios. The size of the 2 babies may be the same. The main distinguishing feature of twin transfusion syndrome is too much fluid in one and not enough in the other. And then we classify the stage based on the Dopplers in the umbilical artery and the ductus venosus. If the Doppler in the umbilical artery and the ductus venosus is normal, then it's stage 1 to 2. And if it's absent or reversed in any of the vessels, in any of the 2 babies, then it is stage 3. And of course, then you have hydrops, and then you have death of 1 twin. If we have stage 1 to 2, the videos don't work, unfortunately, in this platform, then, and you do laser, we hope that in about 90% of the cases, you will have survival of at least 1 baby. And if it's stage 3 to 4, in about 80%, you will have a survival of at least 1 baby. And in stage 1 and 2, 70% of the cases, you end up with survival of both babies, and the rate is lower in the case of stages 3 and 4. On average, and this is a big problem, these babies will be born at 32 weeks, which means by definition, quite a few will be born very early. And mainly as a consequence of that, a few, 5 to 10% of the babies will end up having developmental impairment, mainly driven not by the condition itself, but by the fact that they are born very premature. What about these TAPS? One baby is severely anemic, and that is reflected in high velocity in the peak systolic velocity in the middle cerebral artery, and the other is polycythemic. The one may have a hemoglobin of 2, 3, 4, and the other has a hemoglobin of 18, 20, 22, and has a very low velocity. And it's very easy to see at a glance because one placenta is massive and white. This is the hydropic placenta of the anemic baby, and the other is the polycythemic blackish placenta. We monitor by looking at this middle cerebral artery peak systolic velocity converted into multiples of the median in each baby. And we have stage 1 where the discordance is small, and stage 2 if the discordance between the two is more than 0.7 multiples of the median. And then we also look at the heart to see whether there is tricuspid regurgitation, whether the heart is dilated, evidence of severe anemia like in Rhesus disease, dilated heart, pericardial effusion, abnormal flow in the ductus venosus, and then eventually hydrops or death. And here you have a risk of developmental delay in either of the baby, the severely polycythemic, the severely anemic. What do you do? Well, you monitor very, very closely, at least every week, maybe more often. You see this increasing discordance in velocities. Sometimes there is discordance at the beginning and then they stabilize and you don't do anything, you carry on monitoring. If there is increasing discordance and you are under 20 weeks and it's feasible, I would do laser. Once you hit 28, 32 weeks, well, you may give blood transfusions, but often you have to do a blood transfusion every few days, and the saline exchange transfusion for the polycythemic baby. But by the time you get to that stage, it's best to deliver these babies. And then you have the problem of the selective growth restriction. One baby, normal size, normal amniotic fluid, normal Dopplers, and the other baby, growth restriction, as if it is a singleton pregnancy. And the growth restricted baby is small, the amniotic fluid is reduced, and then we use this graphical classification of dividing them into essentially 3 groups based on the umbilical artery Doppler of the small baby. And as far as I am concerned, it's a combination of umbilical artery Doppler and ductus venosus Doppler. If the umbilical artery in the small baby shows a positive A wave, a positive end-diastolic flow, just carry on seeing them every week, do nothing, and hopefully you will get to 32 to 34 weeks and then deliver them. If you have absent end-diastolic flow, then some people will do an embryo reduction. They do cord occlusion. If we are near 30 weeks, they would deliver. And if, for me, there is also abnormal flow, high PI in the ductus venosus or reverse flow, I would do laser. And then you have this intermittent absent reverse end-diastolic flow where in the same strip, you have positive, negative, and reverse flow. And this is a consequence of the 2 cords being very close to each other. So by definition, you cannot do laser to separate this group. And the only thing you can do is monitor them. And if things are looking bad, we see abnormalities in the brain, we see deterioration in the ductus venosus, either deliver them if you can, because you're near 30 weeks, or some people do cord occlusion. So I will leave it at that. And thank you very much for your attention. And Bhaskaran will now see, unfortunately, we haven't left too much time, but we still have 13 minutes to have any discussion that you wish. So, Bhaskaran, I don't know if there are any questions
thank you, Professor,
system, or if you want to make any comments.
Yes, thank you, Professor, for excellent overview of actually identifying all the various issues which you actually face in management of multiple pregnancy. I think at the end of the day, one of the most important take-home messages is that when we perform a scan, at the end of the day, the diagnosis cannot be one of twins, but one of monochorionic or dichorionic twins. So the chorionicity, this determination of chorionicity has got such great importance in terms of equivalent to just identifying the expected date of management in singleton pregnancies before we make decisions in the entire pregnancy itself. Now, on that note, in most Southeast Asian countries, there may not be actually a universal screening program. Very often, multiple pregnancies are actually first encountered by the clinician at various stages of pregnancy. And so it's not uncommon to actually see the twin pregnancy at 20 weeks and beyond. So where the identifying of the chronicity by way of twin peak sign and so forth becomes not possible. So, Prof, do you have any tip to actually just identify one which you will actually see after 20 weeks when they are concordant for gender and the placenta is, appears to be a single mass? And
that's a problem really. And one of our first papers in the 1990s with Niels Sevier as my fellow at that time was the hidden mortality of monochorionic twins, because when you have severe twin transfusion syndrome, a lot of these babies would have already died. And when you are doing a routine scan at 20 weeks, the condition does not exist anymore. And it was only when you started screening at 12 weeks that you realize this hidden mortality. Now, what do you do once you have reached gestations beyond 20 weeks? The first thing from my perspective is that if you have monochorionic twins, the condition can be so devastating in terms of we have twins and they are now at 24 weeks and one baby is growing well and the other baby is not growing. And then you are wondering, for me, you call them monochorionic for the benefit of management rather than hope for the best that they are dichorionic, because you can easily screw up in your thinking. So you need to almost prove the opposite, Pascal. You need to show that there is good evidence that they are dichorionic. Well, what do you rely on? Well, you have to rely on the placentas, are they separate? You have to rely on the sex of the babies, are they different? And then make a judgment really about the thickness of the intertwin membrane. There is a difference, obviously there's a difference, because in monochorionic twins, you will not have chorion in between, so it's always thinner. And if you have a really nice, good new machines, you may actually see separately the two membranes. Apart from that, my principle is, in terms of management, consider them to be monochorionic rather than dichorionic. I don't know if you have any other suggestions, Pascal.
Yeah, I think that's a very, very important point and take-home message, I think, to it's monochorionic unless otherwise proven.
Yeah.
The point I actually wanted to highlight, and I was hoping Prof will highlight, actually came about is that looking at the thickness of the, for want of any other features, looking at the thickness of the interfetal dividing membrane. And again, as you pointed out, that you have high-end machine, probably tried looking at the separation of membranes. Right. Moving on, I was just thinking about, I will just address various issues as they come along in the interest of time. Prof, you mentioned about doing a single needle incision for sampling twin amniotic fluid.
I like the challenge. Yes.
Yeah. Of course, most times
I feel more comfortable, Pascal. You need to be quite good in ultrasound, really, so that you can align yourself to see the intertwin membrane. And when I see the intertwin membrane and I manage to take a sample from the one, go into the other, then I know that I have sampled them both. I discard the first ml once I go to the other side, and then in one go, I hate needles. And in the last couple of years, I had to have a lot of needles for my condition. And if you can manage to get them both, but be careful. You need to be 100% sure that you know how to do a good ultrasound scan. Yeah.
Prof, your actual technique will be that you will actually introduce with the stillet, sample the fluid. Will you reintroduce the stillet before going on to the second membrane?
Yes.
To a second.
Yeah.
Yeah, we'll do that. Okay.
Yes.
Prof, what's your view with regards to, is there increased risk? I mean, you pointed out later part of the lecture that, that procedure-related risk probably is zero in the best of hands, because you pointed out that the fetus may actually abort because there was already an issue with the baby. And so if the skill was appropriate, the chance of risk of miscarriage based on the skill would be considered almost zero. Now, keeping that in mind, will a two needle insertion technique be higher risk compared to a single technique?
So I don't have a lot of respect for meta-analysis. Quite often, meta-analysis is a sort of a cooking exercise where you use a series of heterogeneous studies and you just mix them up and you produce a summary statistic. To me, quite often those are meaningless. However, having said that, Zarko Alfirevic, who is one of the kings of meta-analysis, and he was in the Cochrane database. They have looked at that, and they showed that it doesn't really make much difference whether you use a single needle or 2 needles, whether you go transvaginally or transabdominally. So we have to accept that. I like transabdominal, and if possible, I like a single needle, but even within my unit, some people most people actually use a double needle. They feel more comfortable. Yeah.
Okay, towards the end of the lecture, Prof, you pointed out that if you actually find there is a discordant abnormality in a twin, and that in a dichorionic, I mean, at 12 weeks, if you did the selective fetal reduction, there's a 5% loss, right? And if you did it at a later stage, it will be 14%.
Yeah.
Right now, I'm, the situation which I mentioned earlier, that we actually meet this pregnancy sometime later on in pregnancy. Is there an option? Let us say if I actually saw this patient at 20 weeks, to allow the pregnancy to continue on to a point of viability where I know I can salvage a normal fetus and then take my chances on that rather than a selective reduction.
Pascal, this is what I call the disgusting but safer option. And obviously, it depends on the law of different countries. Let us play the game. We have seen somebody for the first time at 20 weeks, and we diagnosed an abnormality in that baby at 20 weeks. Let's say the abnormality is Down syndrome, dichorionic twins. Well, in England, it is legally possible to do a termination at any stage beyond 24 weeks. In many countries, it is not. So if it is not legal and you do the termination at 20 weeks, you may have something like a 20% chance that the woman will go into labor in the subsequent 6 weeks. Disaster. So we are doing an embryo reduction at 20 weeks because one baby has Downs, and you have a 20% chance of having a woman deliver at 24, 25, 26 weeks, where the risk of handicap, more severe handicap than the Downs, is increased. So you're absolutely right. It is logical to offer the option if that is acceptable at 32 weeks. But it's horrible. And you have two problems. 15%, 15, it's a lot. It's 1 in 6. Dichorionic twins will deliver before 32, 33 weeks. So you tell a woman, don't worry, come along and we'll do an embryo reduction at 32 weeks. And the night before, out of spite, she delivers and you're stuck. So the management, if you're going to adopt that attitude, is to see this woman starting from 24 weeks, every 2 weeks, to at least measure the cervix. And if you see that the cervix is getting shorter, bring the delivery earlier. Otherwise, you do it at 32 weeks, but it's horrible, really. It's horrible for the patients, it's horrible for the doctors, but that is a safer option. Now, can we do the same in monochorionic twins? And that is really horrible as well. You could potentially, in that case, go to 32 weeks, and in the operating theater, with everybody scrapped and ready to do a cesarean section with an epidural, in front of nurses and anesthetists and everybody else, you put a needle inside the heart, you go into the pericardium, and then you inject calcium chloride and watch the baby to die, and then quickly do a cesarean section. Horrible, horrible condition for everybody involved. But that, at the end, may be the safest option. Pascal, I don't know whether you have any time, but there are a lot of people are asking questions about these TAPS. TAPS is another newly recognized condition where the two babies may be the same size, the amniotic fluid may be the same, the fetal Dopplers, umbilical artery, and ductus venosus may be the same, but one baby is severely anemic and the other baby is polycythemic. The only way to find out if that is the case is in each scan that we do to include middle cerebral artery, peak systolic velocity. What else, audience? What is the ideal gestational age for delivery? Dichorionic twins 36, 37, monochorionic 36, amniotic 30, for me, 32 weeks. How do we diagnose twins during early ultrasound scan? I'm not sure what is early ultrasound scan. Well, in most of the time, countries where they do an early scan, they do it at 11, 15 weeks. make damn sure that you're holding the transducer transversely and you start from the lower end and you go up. If you go only longitudinally, you may easily miss another of the two babies. Always transversely, a sweep up to make sure that you're not missing one baby. What else, Bhaskara?
One or two more before we close the session. I think we're really running on an interesting note, but time actually is of one. You mentioned about when we do a CVS for when you actually try to get to the furthermost point of the placenta on either edge, right?
Yeah.
Is there an option to actually consider getting to the nearest point at the root of the cord?
So
here's the equally effective.
Here's the placenta. Here's the placenta. We find the intertwin membrane, and we assume that the junction of the intertwin membrane is also the junction of the two placenta. That is not true. This placenta may be extending beyond the intertwin membrane, and that is the problem. And we had that happen in our unit, where you sample one baby on this side, you go across the other side, and you sample what you think is the other baby, but actually you have sampled both the same baby twice. So I would go there and there, extreme ends.
Okay. What I meant was if he actually got to the root of the cord.
That's a bit different. Yes, that's different. Yes, you're right.
That would, yeah. Okay. Just maybe a final note, just regarding cell-free DNA in twin pregnancies. You mentioned that in I mean, we should ideally be looking at the biochemistry and nuchal translucency because of the numbers are actually shortcoming. But we look at the percentages, it still seems to be that for Down syndrome, you actually get a 97% sensitivity. What's
maybe more even, Bhaskara. So I think that the results are reassuring, and I certainly do it in my practice. But I tell them that it's quite good for Downs, but I am uncertain about trisomy 18 and 13. Is trisomy 18 and 13 important? Maybe not. In the sense that in a hell of a lot of them, you will see some major abnormality early, number one.
That's right.
In a hell of a lot of them, actually, from doing the combined test, you will see a high risk from the combined test itself. And in any case, at the end of the day, if you get it wrong, it may not be such a major disaster because the condition is self-limited, isn't it? You're not going to have a baby that will be severely handicapped and live for many years. So I think it is reasonable to be offering cell-free DNA testing in twins as well.
So, and I think it'll be good to just follow the same rules that, you want to do your anatomical scan as well to ensure there is no defect before you actually perform the NIPT. On that note, I'm just wondering whether in a twin pregnancy, is there a role to actually consider NIPT just to pick out zygosity very early on in the pregnancy? That's my last one.
Yeah, so some of the cell-free DNA companies, maybe most of them now, they're doing zygosity as well. I think it's worthwhile. In the beginning, I was skeptical. I was thinking, but what is the benefit of this? Well, the benefit is, as we mentioned, out of 7 dichorionic twin pregnancies, 1 will actually be monozygotic. So I think it's good to know about it. It won't change your management in terms of delivery and so on, because it's chorionicity that matters, but in terms of fetal abnormalities, and back to the issue of testing both babies, I think it's worthwhile knowing. So if you're going to do the cell-free DNA test, you might as well actually ask also for zygosity.
Okay, thank you, Prof. I mean, that was a very interesting introductory session. Really want to thank Prof for giving such a comprehensive lecture, and I think the discussion went on very well. I hope there was a lot of take-home messages here. On that note, return the stage to the chairperson. Thank you.
Thank you, Bhaskara. Thank you. Yeah.
Thank you, Prof.
Leona.
Oh, so thank you. That was really, really good. Very interactive. And I think, as you've mentioned, many take-home messages. So we would like to invite the next session to come along.